Baba, this is Juan and I am doing Amboss. And I noticed that when I do Amboss, I tend to be really silly because I like to make study sessions a bit more entertaining for moi and by extension for you guys. And so what I'm going to do is I'm going to do a little snippet of me doing my in-study commentary. You guys are going to be watching me as I comment. Okay? So the following is the most appropriate step. Without further ado, it's Juan doing random Amboss questions. 32-year-old man's brought to the emergency department after a car accident. He was extricated after 4 hours. Extricated. Was he extricated intricately? Huh? Huh? Oh, shut up. Did not lose consciousness. Appears not to have a nausea or a headache. He's in severe pain. Of course. Severe injuries to both arms. Surgical intervention is needed. Oof. Dark colored urine. Multiple injuries to... Okay, look at his blood pressure. It's going down there. Multiple injuries to the upper extremities. Contusions. Abdominal tenderness. Abogas show a pH of 7.3. Bicarbonate is low. Okay, ECG is shown. Let's look at it later. Fast scan of the abdomen shows no free intra-abdominal fluid, so that means he has some blood loss somewhere. Okay, the kidney, the potassium is through the roof, and so he is unstable, but his blood pressure is down there. So we need to stabilize him via circulation. So let's first check what we do need to give. His potassium is low, so definitely we'll give calcium gluconate. Mannitol, no, there's no real signs of brain problems. Insulin, not really. He's not like too hyperglycemic. In fact, if you give insulin, it's gonna get rid of his glucose. Packed blood cells, definitely. Norepi, not really. His pulse is still up there. So, of the three, what are we gonna give? Bicarbonate? No, maybe he'll stabilize if we manage the underlying causes. Calcium gluconate or packed red blood cells. ABC. C. No, not even. Oh my goodness. So we do the calcium gluconate first for hyperkalemic emergencies. Really? So we don't do circulation first. Let me see. Okay. Okay, it's very nuanced. Hemoglobin is still above 7. So if it's below 7, that's when you need to give the RBCs. Nuance. It's all nuance. Poop face. Alright, greatest risk for which of the following complications? Emergency death because of muscle soreness, nausea, dark urine. So on the college track team, training intensively for rhabdomyolysis, I'm guessing. Okay. UTI, nitrofurantoin, healthy. Blood pressure is normal, pulse is normal, no abnormalities, abdomen soft and tender, diffuse muscle tenderness, laboratories show, let's check that later. Hemolytic anemia, not really. Myocarditis, Not really. Metabolic alkalosis. No, he's at risk for acidosis, as a matter of fact. Compartment syndrome? Maybe. Acute kidney injury? For sure. Sweet sauce! Perfect. Okay, next one. By the way, at this point, I would only like to have... I'd like to have only maximum of 3 more mistakes. Okay, next step in diagnosis. We have a 31-year-old man comes to the doctor because of flank pain and blood in his urine. He was treated for UTI 3 weeks ago. That's telling. Was he given an antibiotic? No. He has hypertension treated with enalapril. Daddy died at 43 for a ruptured cerebral aneurysm causing a subarachnoid hemorrhage. BMI is huge. I'm not doing a biopsy. Wait a minute. Flank pain, blood in the urine, urinary tract infection. Wait a minute. Dad died of a subarachnoid hemorrhage. Let's do a renal ultrasound. Why? Maybe he has achypicide. Apicide. Let's see. Arteriography. Not really. Pyelography. It does not look like an infection. Urine cultures, as I said, it does not look like an infection. Genetic testing. Hey, you do that down the line, but first you need to rule it out. Sweet sauce! Apicide! Okay. Urinary frequency. What caused the patient's urinary frequency? 63-year-old woman comes to the doctor because of a 4-week history of increased urinary frequency, bone aches, nausea, and fatigue. Oh, it sounds like a calcium problem. Stones, bones, groans, psychiatric overtones, right? Okay. Thirsty, drinking 5 to 6 liters of water daily. Oof. Waking up frequently during night to the urine. Waking up frequently during the night to urinate. So she has TDDM, type 2 diabetes mellitus, MDD, hypertension. Drinks a beer per night. I mean, that's not wrong. Dry mucous membranes. Let's check the urine. How's the calcium? Ooh, it's through the roof, my friend. Okay, how is the sodium? It's a bit high. The urine osmolality is low compared to the blood osmolality. Okay. Water deprivation, plasma and urine is the same. So it doesn't concentrate after water deprivation. 1 hour after desmopressin or ADH analog, plasma is still about 300 and urine is still about 260. So it doesn't concentrate. It's not concentrating. It won't cooperate. The kidneys aren't cooperating. And so the problem seems to be nephrogenic diabetes insipidus. So let's see her drugs. Lisinopril, escitalopram, metformin. I'm not sure which of these would cause nephrogenic diabetes insipidus. But she has type 2 diabetes mellitus. Maybe the type 2 diabetes is causing the diabetes insipidus. Anyway, let's see. Sweet sauce! Oh, hypercalcemia can cause nephrogenic diabetes insipidus. I'll put that in my to study. Great. Next up, most appropriate next step in management, severe headaches, past 3 months, pulsating, 8 out of 10 in intensity, woof. Emergency department, headaches happening twice per month, blood pressure is elevated. Ooh, sounds like a medullary adrenal problem. Okay, wait. Hirsutism, abnormalities, abdominal bruit. Oh. And, renal artery alternation. Narrowing in the renal artery. Next step in diagnosis. What test do we do? Or angiography. Okay, what percent? 75% reduction. Drug therapy is not going to be adequate for this. Angioplasty. With stent placement. Oh, poop. What? Okay. Fibromuscular dysplasia. Really? So you don't want to put stent placement. Why not with a stent? Okay, that's the intent of the stent. The intent of the stent is to prevent the descent of the layers of the renal tent, the renal artery tent. Oh my gosh. Fibromuscular dysplasia, angioplasty. Got it. Alright, diagnosis, flank pain, past 2 years, had several UTIs, bilateral non-tender upper abdominal masses, blood pressure is high, urea nitrogen 29, creatinine is 1.4, that should be at least 20 bun ratio. We have adipicade. It's fun to say. Adipicade. Who left? No. Alright, most likely to develop in a 2-year-old girl, high-grade fever, crying while peeing, treated for a febrile UTI with cefixime 4 months ago. Urine culture shows E. coli is sensitive to cefixime. That's good. Voiding is shown. If you don't treat it, it's gonna back up and it's gonna cause dilation of the ureter and maybe the kidney, and that's gonna cause scarring. Yep. Yes, got it. One more question to go. Most likely explanation for what symptoms. So we have a 51-year-old woman who comes to the doctor because of a 1-month history of daytime sleepiness and a dry mouth. Sleepiness is due to getting up to urinate several times per night. She's also had increased thirst. Ooh, that's a lot of water, my friend. 20 cups of water per day. Does not feel an urge prior to urinating. Has not had dysuria. History of multiple UTI infections. Suicide attempt. Oof. Head trauma. Does she have central? She has bipolar 1. Hypertension. Membranes are dry. No suprapubic tenderness. There's a neurologic tremor in both hands. Sodium concentration is high. Elevated ADH. Okay. That's it. That's central. It's not so much the new mood stabilizers. It's not psychogenic. It's hypothalamic injury. Why would an injury cause... Yes. Come on. Click on it. Click on it. Ah! No. Is she taking lithium? Come on. She had the head trauma. Oh my gosh. She has elevated ADH. Oh, I didn't pay attention to that. Oh well. I hope I got more than 65%. Ah, man. If only for that last careless mistake. Anyway, that's how I study. I hope you guys found that at the very least entertaining. So, that's all for now. Until next time, guys, remember, always live life to the fullest, because you only have one life to live.